Welcome back to the latest installment of the presentations for the Movement Professional Mentorship. Today we're going to expand on what we've talked about in the past with continuum-based thinking, as well as the last presentation we did on the movement continuum, where we discuss pain as one of the major markers of control for knowing what somebody's ready for within a movement. So today we're going to look at pain from two different perspectives. Notably, we're going to look at how many different ways can we safely provoke pain to see where somebody's pain starts so we know what they're safe to do and what we have to be a little bit more cautious with. So the pain provocation continuum would be a series of phenomenon that induce the onset of pain or any subjectively dangerous symptom. So it doesn't have to be pain. It can be just something that someone doesn't feel safe with, or something that somebody feels threatened with as we go through some type of movement process. And usually there's going to be a complaint first that an individual has, that they're struggling doing something, and we have to figure that out. And then we want to assess that movement, that activity, and we're going to use the movement continuum, which we talked about a couple of weeks ago. And then here, even deeper within the movement continuum, we'll look at how to break down how you might find someone's edges of their pain experience or their symptomatic experience. So we're going to ultimately be finding out where we need to be cautious and where we're good to go. So the progressive provokers that we're going to look at are graded motor imagery, graded direct pressure application, graded passive and active motion, graded isometric resistance, graded concentric and eccentric resistance, tempo manipulation, volume, duration, frequency manipulation, and finally, graded novelty manipulation. So most of the presentation will just be diving into these different provocation signals for pain. So graded motor imagery is, I would say, not often used in the clinic, but to me, it's important to know that it exists and that there's research behind it. And this would be basically your pre-movement assessment. Or it could be your pre-movement training in many ways if you can't find a movement for the movement that someone's complaining about that isn't provoking pain. So graded motor imagery basically looks at assessment and trying to build some skill before movement even takes place. So it could be broken down into 3 stages, or it's studied in 3 stages by the Neuro Orthopedic Institute out of Australia. So you got guys like David Butler, Lauren Mosley that put some work in, some research into this. The 3 categories are left-right discrimination, explicit motor imagery, and mirror therapy. Left-right discrimination is ultimately the ability to identify left or right images of a painful body part, or it could just be even non-painful, and just how good are you at being able to tell your left from your right in different circumstances. And once I've learned about this, you could really see that some people have a much harder time with this than others. And that can lead to actually a longer pain experience. So it is something that is trainable. Sometimes it's just trainable through movement over time if there's not a specific symptom, but it can also be trainable with certain apps. And specifically, I put a link to these recognized apps, which is through this NOI group. And it basically is just like brain training to identify different body parts and see how quickly and how accurately you can identify if it's left versus right. And it starts with just something that looks very much like a human body part in a normal orientation, and then it can be progressed to more abstract art in all different orientations, and can you quickly still identify what is left, what is right. It's an interesting process, but there does seem to be some research behind it that shows that it's important for normal recovery from pain. Explicit motor imagery is basically just visualization. So thinking about the movement before you're actually doing it, it can be actually quite useful. Again, it doesn't have to be in a situation where no movement can be done that doesn't provoke pain, but it can also just be added to anyone's movement practice to actually discuss visualizing a movement before you're doing it, especially something that had been problematic, and just see what comes up for the client. Imagined movements can actually be hard work, especially if you're in pain chronically. And the mechanism seems to be related to mirror neurons that start firing when you think of moving or even watch someone else move, which is pretty interesting. Mirror therapy would be using a mirror to basically deceive your brain into believing that the reflection of one limb in the mirror is actually the opposite. So if you're looking at your right limb in the mirror, you're actually tricking your brain to think it's your left or vice versa. So you have two options here how you can use this. You can have the individual move the non-painful side, but the brain is perceiving that you're moving the painful side. And that could just be a way to start the process of getting more movement on the painful side. Or the opposite would be you actually move the painful side and the brain is perceiving you're moving the non-painful side. So both are options in this assessment and this treatment. Next would be graded direct pressure application. And none of these provokers are in a like linear process, right? So you don't have to do one before you do the other, or you don't have to like never get to graded motor imagery because people can move without pain. You could be using all of these in combination. It's just a way to look at everything as sort of this game of inches. And you'll find that some people respond better to different types of ways to get people moving safely. So these are basically broad categories that you can use in any order and any combination to try to see what somebody feels safe with. So when we're looking at direct pressure application, it's basically the progressive increase in contact that's administered to a painful area. And two movement practices that come into mind here. One would be manual therapy, where someone's actually putting their hands on you. You can think of it as massage therapists, very specifically the Maitland Australian physiotherapy seminars. Their practice of doing manual therapy really uses this idea of graded direct pressure application to see people improve over time and actually be very specific for creating change with pain. And their methodology, which I've gone through the whole certification process for, and had training from some of the people that were involved in the actual origin of the practice. I found it quite useful for really understanding how gradual and progressive you could be with manual therapy. A lot of times you think about somebody putting their hands on you, a chiropractor or a physical therapist, and you think they're just going to try to put something into place. They're trying to move something that was out of place, as opposed to thinking of it as what we're actually trying to do is gradually get people more tolerant to deeper pressure, or a pressure that was at one point threatening. We're trying to get them less threatened by the pressure, because it can be varied. It can be deep pressure, light pressure, vibratory pressure that people respond to better. But the idea is that it is a training. It's a gradual, progressive ramping of oftentimes the depth of pressure. Someone might start by having a threat very much on the surface of the skin, but over time can tolerate pressure that's deeper towards the skeleton. So that was the practice through that I learned through Maitland Australian physiotherapy seminars with using my hands, which can be very specific and very useful. And ultimately, like you're trying to find where the pain starts with the depth of pressure that you're adding. And you can also look at where resistance of the tissue starts, which, as your manual therapist, your fingers get more fine-tuned to that. And that could be helpful to see like pain starts way before you even really get to tissue resistance, or you get to tissue resistance and you're pretty deep into that before pain starts. That can give you different information of how you want to treat that person. Outside of manual therapy, though, just the application of pressure that we could do to ourselves, which would be like self-massage type of work. And I think this is an important distinction from just looking at taking some pressure and making it hurt in areas that are already hurt. There really can be a graded process and progression when we're doing self-myofascial release or self-massage, whatever you want to call it these days. I like to think of it as pressure therapy, so I can make that distinction from it being just some version of massage where we just, direct intense pressure into an area and try to eradicate pain by creating more pain. But it's really about figuring out what tool can you use, what body position do you have to get into to find the onset of your pain, and really make that important first. It's not more the merrier. It's really, where does the onset of my pain or my threat start? And can I have a process for allowing my body to relax into that pressure gradually over time? And oftentimes that connects to breath control and nervous system control, that we're actually able to feel an initial pain, but not run away from it notice what our body wants to do to guard and sort of run away from it, but be able to actually stay there and explore and be curious about it. And then what we'll notice is that we can actually tolerate more depth of pressure as we hang out there longer, which is really confirming to our nervous system. If we can do something longer, uh, we're confirming that it's not as much of a threat, because most of the time we want to be running away from something that is a threat. But if we actually stay with something and have a process for staying with something, and we actually feel less pain as we hang out in a place longer, then that is confirming that we've done something to desensitize the pain in that moment, which could be very valuable. The next provoker would be graded passive motion, and this is just any motion that's happening either by somebody else or by some other entity. So the therapist is moving your shoulder, or you're using a band or a pulley to move your shoulder as opposed to you're actively moving it yourself. And what we're trying to find is, again, the onset of the pain during this process. So this is very common when you go to a physical therapist. They might put you on a table and then they just might move your limb for you. And what they're looking for is the provocation of any pain and any resistance and limitation in range of motion. So the difference here is that there's very minimal muscle activity, hopefully. And certainly when you're moving with a more complex movement, say you're trying to make your squat a little bit less active, or you're making your push-up a little less active, there's going to be a combination of active and passive motion involved. So there is a little bit of a spectrum between graded passive motion and then the next topic, which would be graded active motion. But the idea here is that we're adding more support to the area that's injured or painful to make it not have to do as much work. And mostly the muscle activity is what we're trying to calm down there. And when you're, as a therapist or as a movement professional, if you're moving a limb, one thing you can actually grade is how much you support the limb during the movement process. So if you grab, say you're moving a shoulder and you put your hands very much like on the shoulder joint, typically you're going to be supporting that shoulder more. It's going to be less likely to be painful versus if you're moving somebody's shoulder by grasping their pinky or their finger and you're just moving from that distal segment and you don't have nearly as much support on it, it's going to be a very different process. And that could be a progression in itself to see how much somebody tolerates it, how much do they need support when you're moving their limb. Again, the progression then becomes graded active motion, which we're trying to take support away, and we're having the individual do more of the action on themselves. So we're seeing when the onset of pain would be when you yourself raise your painful shoulder. When does it start? As opposed to some other entity moving. And again, then there's this spectrum of moving from passive to active, which is called active assistive motion. And we're looking at how much assistance is required by another person or entity to eliminate the pain. Once we go through this type of process without any resistance, other than maybe some resistance from gravity, we can start adding resistance into this process of trying to provoke pain. So the first step here would be adding isometric resistance, which would be adding resistance to a joint that's not moving. The position remains unchanged, and we're trying to ramp up this isometric contraction. So basically, someone could hold their shoulder in a position, and you say, "Don't let me move you," and then we're seeing how much we can ramp up that contraction before they would have pain, or we can have the individual do it themselves in some way where they're pressing a limb into a wall or an immovable object, and they're ramping up a contraction to see when the onset of pain would be. So typically, it's really important to educate a client on a ramping up process for isometrics. It should be kind of common sense to a movement professional, but it's often not for someone who's not in that process. You're basically just telling him to make something tight or make something squeeze. They may have no reference for that. So there's quite an education in teaching a ramping up of an isometric contraction. So I like to use a 0 to 10 scale where you're just saying, just try to get that muscle firing at 1 out of 10 and gradually ramp it up to as high as you feel you can, understanding that there's a max level there that might be 10 out of 10. And you can use a actual 10-second ramping process where you do the first 2 seconds, you're just sort of ramping it up. For 6 seconds, you're actually looking at trying to optimize or maximize the intensity that you could turn up that contraction, and then you have 2 seconds to ramp down. That I find to be a useful process when I'm trying to teach somebody how to grade how much resistance they can use in an isometric. Right? And it can obviously be assessed at various joint angles, so it can be quite useful, especially with a shoulder or a hip where you have a lot of range of motion. Usually there's just one part of the range of motion that is the most painful. It's not the entire range of motion, so you can work either right before the onset of pain at that angle, or you can work into it gradually or just the beginning of it and see if the graded isometric resistance starts to build over time, which is another way of teaching the nervous system that things are safer because you've taken the time to gradually ramp up this isometric contraction right at that onset of pain. And sometimes you find that, the pain actually dissipates within a session. It might be back the next session, but it becomes a nice teaching process to show an individual how to control their own pain.